Good day, viewers. A Quad Blog is reporting live at the Nigerian Institute of Medical Research, NIMR, for the April edition of the NIMR Media Chat. Today's discussion is set to focus on discourse around tropical diseases resulting from the research conducted across waterlogged areas in Lagos, such as Schistosomiasis, Buruli ulcer, as well as soil-transmitted Helminthiasis. So stay tuned as the Quad Blog brings to you all the live coverage of the event as it unfolds. I am Daniel Samson Idowu, reporting for Echo Hot Blog.
The Nigerian Institute of Medical Research, NIMR, has been on a streak of medical engagement and public advocacy through its monthly conversation with the media about the emerging health trends in the nation and insights on salient but prevalent diseases and pathogens across various communities in the country. This conversation, tagged NIMR Media Chat, was the brainchild of the Director General of the Nigerian Institute of Medical Research, Professor John Oladapo Obafunwa, who perceived the need to keep the public up to speed with vital health information and findings of the Institute in a bid to mitigate widespread health crises in the country through timely advocacy and public health education. April's edition of the NIMR Media Chat was no exception, as the Director General, Professor John Oladapo Obafunwa, led the executives into the boardroom for the discussion, which centered on presentation of the findings from research conducted by the Tropical Disease Research Department in some areas across Lagos. The presentation was anchored by the department's director, Professor Olaoluwa Phebian Akinwale, the Director of Neglected Tropical Disease Research. The study was focused on discovering the distribution of neglected tropical diseases and their intermediate hosts that are crucial to public health and well-being in Nigeria, including Schistosomiasis, soil-transmitted Helminthiasis, and Buruli ulcer. Employing various parasitological and molecular tools, the study set out to find the frequency and patterns of these diseases, the reasons for their occurrence, and how the findings can be used by national and state disease control programs for planning, evaluation, and management of these diseases. Professor Olaoluwa Phebian Akinwale dived into the thick of the discourse by introducing the major focus of the study and how the research procedures were painstakingly done to ensure the credibility and reliability of the research findings.
Some of these diseases are prevalent in many parts of Nigeria. Some are found in all the states of the Federation. Some are located in particular regions depending on the weather. The most common among these infections in Nigeria are Buruli ulcer, human African trypanosomiasis known as sleeping sickness. We have leprosy, lymphatic filariasis that is commonly called Helminthiasis, then onchocerciasis known as river blindness. We have Schistosomiasis, which is blood in urine. We have soil-transmitted Helminthiasis, such as roundworms, hookworms, whipworms. Then we have the blinding trachoma. These are major infection, tropical diseases that are common in Nigeria. We also have yaws and the likes. So my team's activities, when I say my team, including Dr. Giang, our research activities include conducting studies on the distribution of some of these entities and understanding their intermediate hosts and vectors that are of public health importance in our country. We employ various parasitological and molecular techniques to investigate the frequency and pattern of these entities, the reasons for their occurrence in the country, and how our findings can be utilized for planning, evaluation, control, and management of the entities. We also conduct training and workshops on the application of these techniques to identify the causative agents, that is the parasites or the bacteria, and their intermediate hosts. Currently, we are collaborating with the University of Cambridge in the United Kingdom to study the epidemiology of schistosomiasis, the blood in urine infection. We are using a One Health approach, studying the parasites from the human and animal angle, as well as the environment. So the study is ongoing and is funded by the Cambridge Africa Research Grant.
Summing up the overview of the schistosomiasis trend, Professor Olaoluwa revealed that millions of girls and women of childbearing age in sub-Saharan Africa, including Nigeria, are at risk of urinary schistosomiasis due to continuous exposure to infected water sources, including domestic chores, and particularly how urinary schistosomiasis leads to female genital schistosomiasis, a gender-specific manifestation of the infection.
Urinary schistosomiasis, as the name implies, is a type of NTD that causes blood in urine. That is, the infected person urinates blood along with in the urine. So the infection impacts millions of people all over the world, especially vulnerable groups such as children and women of childbearing age in sub-Saharan Africa, including Nigeria. We also know that the disease also manifests as a gender-specific infection in some cases. The urogenital schistosomiasis could affect the genital organs of the patients, especially the women. So the gender-specific manifestation of this infection is known as female. It's known as female genital schistosomiasis. In Nigeria, there is paucity of data on this gender-specific manifestation of urinary schistosomiasis. So our study now aimed to contribute to the much-needed data so that we can create more awareness in the country.
As some women within the childbearing age bracket were sampled, findings revealed that almost half of the women were infected with urinary schistosomiasis, with younger women being significantly more infected. Photocolposcopy showed that about half of the infected women had signs that could be considered as female genital schistosomiasis, including grainy sandy patches, yellow sandy patches, abnormal blood vessels, and rubbery papules. Also, their pap smear results showed abnormal cervical manifestations, while Professor Olaoluwa recommended that more measures need to be taken to improve the health of women, especially those living in schistosomiasis endemic communities.
So we set out to screen women of childbearing age in some schistosomiasis endemic communities for the symptoms of this female genital schistosomiasis to determine the prevalence of the infection in the communities. We used microscopy, urine microscopy, clinical examination, pap smear, and photocolposcopy to screen the women using the WHO FGS Pocket Atlas as our guide. The study received funding from grants awarded by the Royal Society of Tropical Medicine and Hygiene and the National Institute for Health Research in the United Kingdom. So our findings, almost half of the women that we screened were infected with urinary schistosomiasis. Mind you, these are women living in schistosomiasis endemic communities, so it's no surprise that half of our participants had this infection. Younger women were significantly more infected. Then the photocolposcopy results show that about half of the infected women, not half of the participants, half of the infected women had signs that could be considered as female genital schistosomiasis. These signs included graining sandy patches, yellow sandy patches, abnormal blood vessels, and rubbery papules. We worked with clinicians who were trained on colposcopy so that they helped us to interpret the results. And the pap smear results also showed abnormal cervical manifestations So our recommendations were that more measures needed to be taken to improve the health of women, especially those living in schistosomiasis endemic communities. While all our infected women in the study showed cervical cells that deviated from the normal appearance or structure, it is important to follow up with them to monitor any potential progression of these cells that could lead to malignant lesions. So we strongly recommend that more studies should be conducted with larger sample sizes in these communities and in other communities where this infection is endemic. Those are our findings and recommendations.
Moving on from the conversation about schistosomiasis, Professor Olaoluwa talked about another endemic disease called Buruli ulcer.
Then our second disease is Buruli ulcer, which is also common in Nigeria, but not as common as urinary schistosomiasis. The WHO has set a test known as polymerase chain reaction confirmation rate for at least 70% of cases of Buruli ulcer that are clinically diagnosed in the country. These cases should also be confirmed by PCR because microscopy that is commonly used in the field to confirm these cases is not as sensitive or specific as PCR. PCR works with the DNA of the parasite. So whatever the amount of the sample, if the bacteria that causes Buruli ulcer, Mycobacterium multirans, is in the sample of the patients, the microscopy can miss it, but PCR will pick it up. So WHO now recommended that every country reporting cases of Buruli ulcer should subject at least 70% of their cases to this PCR confirmation because the treatment is for 8 weeks, a daily dosage of antibiotics. You will subject a patient to such. So care must be taken in order not to treat a patient using false positive results. So that is the essence of this PCR. As of 2015, the National Buruli Ulcer Control Program in Nigeria was faced with significant challenge due to the lack of access to in-country PCR confirmation. So we saw this gap and applied for a grant from WHO TDR to establish this PCR confirmation in NIMR. And as by 2016, we were able to establish the Buruli Ulcer Reference Laboratory for PCR confirmation in the country. And the laboratory is domiciled in NIMR with funding from WHO TDR and support from NIMR. And NIMR has, in that wise, helped to ensure timely diagnosis and improved treatment outcomes for patients in the country. Then we looked at our data over time, and our findings since 2016 showed that the Buruli ulcer is not as endemic in Nigeria compared with some other African states. It has low prevalence. And then the results also showed significant difference between males and females in terms of the infection. No significant difference. So there's no difference between how many males are infected or how many females. But we observed that individuals under the age of 50 are more affected than the older age groups. Then our samples have been coming since 2016. We have been receiving samples from about 21 states, but most of the states are from the southern part of the country. And it's not a surprise to us because this infection is found in places where we have heavy rainfall and humidity. So finding more cases in the southern part of the country is no big surprise. Then our recommendations. Given the results showing low prevalence of Buruli ulcer in Nigeria, we recommend the following. That clinically diagnosed BU cases that we now find to be PCR negative should be further screened for other NTDs like yours that present clinically like Buruli ulcer. So that even if the patients are negative for Buruli ulcer, they can still be treated for the particular NTD infecting the patient. And then we also advocate for increased government sensitization, especially at the grassroots level. Then there should be improved active cases by health workers, especially in rural areas, so that more cases will be discovered for timely intervention.
The conversation then continued with several contributions from the research team members. Dr. Vincent Gayan discussed soil-transmitted Helminthiasis, particularly emphasizing the overall prevalence of the disease among the children was nearly 90%, with round 1 being the most common infection.
Like in our study in an urban slum here in Lagos, the children were screened and over 90% were positive with intestinal parasites. And of those 90%, about 50 had multiple infections. Some had 2 worms, some had 3 worms, which exhibited different morbidities in the children. So we now went back to the community and gave them our recommendations. We now advise that those communities should have more regular mass deworming programs, and there should be more education on health hygiene in that area. We also advise that they should have safe drinking waters in those communities. And then lastly, we advocated for the complete stoppage of open defecation, since the route of infection is the oral fecal route. That is, we pick it from what you eat.
Dr. Abraham Ajayi digressed further by introducing another tropical infection called non-typhoidal salmonella infection, a germ-negative bacteria that primarily causes gastroenteritis, bacteremia, and focal infection. Symptoms may be diarrhea, high fever with prostration, or symptoms of focal infection.
People have this diarrhea which will go after a period of time, and before they even go to the hospital, they self-medicate. It's only when it is severe that you see them come to the hospital. And we've looked at it and found out that there are a kind of evolution in the strain. Some of them are becoming more invasive than what it used to be. So even from animals, we actually isolated some of these organisms from food animals, poultry, sheep, cattle, here in our environment. So the recommendation would be that we should look critically into it. When people are cooking, they should cook their food properly and try to be very hygienic, because you don't use the knife, for example, you have used in cutting poultry products, meat, to cut vegetables or other things that you will consume without further processing, because cross-contamination happens. And that is the major route where people can get infected with this pathogen. So more funding is also needed, and we have to beam the light towards the non-typhoidal salmonella infection around us.
Professor John Oladapo Obafunwa further raised the issue of epileptic power contract with the Eco Electricity Distribution Company, citing concerns over exorbitant charges and lack of transparency in the DISCO company's dealings with NIMR.
I previously raised some concerns. What I still consider to be deliberate attempt to frustrate NIMR. And I'm talking about power supply. I once told some of us that because of this so-called Band A and what have you, Eco Electricity gave us a bill of almost 49 million for the month of August. 48 million or so for the month of September. October, 44 million. I don't know what we are consuming. We've had to shed though in the residential quarters. In the residences, power is shut down at 9 a.m. and restored at about 4 p.m. We have research going on in NIMR. We have equipment that are temperature sensitive. We have reagents. We have samples, biological samples to be analyzed. These reagents often provided for by foreign donors. Equipment provided by foreign donors. I tried several times to explain to the authorities of Eco Electricity that we can't afford to shut down NIMR. We've had to depend to a large extent on foreign donors to assist us. But it's like some people don't seem to get it. They don't seem to understand the importance of research within the society. We've tried several times to explain the fact that we are not a tertiary health facility generating income from patients. Even if you have to go to the neuropsychiatric hospital, you pay. We're not that kind of facility. We're not a tertiary educational institution. We don't have the number of students that you have, whether it's University of Lagos or Lagos State University, whatever, that pay school fees. This is a research institute. To worsen the case, there is no meter in NIMR. We keep getting estimated bills. And when we approach them, that look, let us have a meter so that we can check what you are billing us for. They refuse. 2 different officials told me, forget it, we won't give you. If the meter for NIMR is supposedly located at their Jibowu office or somewhere, and I said, you can put a meter in your backyard and be giving us figures. We've written several letters to Eco Electricity stating this abnormal situation.
Following the DG's claim about EcoDisco's double-handed dealings with NIMR, several questions were raised over the lingering issue of exorbitant charges, with solutions geared toward an alternative power source, such as a mega solar power system. Attention was then turned back to the discussion of the day as several questions were raised about the degree of prevalence of schistosomiasis, Buruli ulcer, and soil-transmitted Helminthiasis. Professor Olaoluwa provided precise answers about the endemic nature of the diseases.
The disease also manifests as a gender-specific infection in some cases. The urogenital schistosomiasis could affect the genital organs of the patients, especially the women. So the gender-specific manifestation of this infection is known as female. It's known as female genital schistosomiasis.
Indeed, this timely conversation about prevalent tropical diseases across Nigeria is crucial for adequate public health education and advocacy to avert a widespread health crisis in the country and keep the general public informed and alerted to their general well-being. For Echo Heart Blog, this is Daniel Samson Idowu.
Indeed, it has been a moment of thoughtful conversation and expert analysis on the prevalence of tropical diseases across some communities in Lagos, according to the findings of the experts in the industry right here at the Nigerian Institute of Medical Research on the occasion of its April edition of NIMR Media Chat. Thank you for staying tuned. Do not forget to follow us on all our social media platforms on X, Instagram, and Facebook at Echo Hot Blog. Also subscribe to our YouTube channel at Echo Hot Blog. I am Daniel Samson Idowu, reporting for Echo Hot Blog.